Good afternoon, everybody, and welcome to the webinar. Today we are in our Beyond the Numbers series, and our session today is on Your Doctor Prescribed You What? A review of lipid-altering therapies. So if you all have been with us, we have been going through the different aspects of lipid control, and we're so excited to bring this one to you today. Before we get started, I just want to introduce to you briefly the three organizations that have been partnering to bring this webinar series to you. The Mended Hearts, on our mission is to inspire hope and improve the quality of life of heart patients and their families through ongoing peer-to-peer support, education, and advocacy. We are partnered with the National Lipid Association, and their mission is to enhance the clinical practice of lipid management in clinical medicine. And the foundation of the NLA's mission is to improve the welfare of patients and families affected by triglyceride and cholesterol problems. A couple of reminders before we start. All attendees are in listen-only mode. If you can't hear, I hope you can read the screen. Check the audio button on your personal computer to assure the sound is on. Please type any of your questions into the Q&A box at any time during the presentation. Your questions will be read and answered after the presentation is over. You don't have to wait to the end to add your questions though. Just as a note, the presenter will not be able to answer questions about you specifically or about your loved one, as she is not your treating physician. And finally, a PDF version of the slides, as well as a recording of this presentation, will be available on the Mended Hearts website following the event. So I'd like to introduce to you our panelist speakers today. We first have the pleasure of welcoming Dr. Zareen Fakhari. She is an associate physician at the Division of Cardiovascular Medicine from Brigham and Women's Hospital in Boston, Massachusetts. She's instructor of medicine at Harvard School in Boston. We also have with us Rob Bray, who is a patient representative who is going to be able to talk about his personal journey with lipid management. I am Andrea Baer, the executive director here at Mended Hearts, and we are going to get started. So before we get started, we'd love to do the polls to see how much information you know before we do the webinar and then after. So I'm going to launch the poll that is on the site or on the screen now. If you all could answer the question, what you think the answer is now, and then we are going to retake our quiz at the end to see how much we learned during the presentation. So it does say many medications lower LDL cholesterol in the bloodstream by, how does that work? Is it by decreasing the number of LDL receptors on the cell surface, increasing the number of LDL receptors on the cell surface, or I don't know? And I don't know is always an acceptable answer. So we're going to give this just one more second, make sure everybody gets a chance to put their answer in. And then we're going to get started. All right, we have got 82% of people in, and so I am going to share the results so you can see. I don't know the answer maybe either, so I'm not going to give the answer. We'll let the doctor give that. All right, so now I am going to turn over my controls to the doctor, and she is going to get started. Give me 1 second.
Okay, great. Thanks very much, Andrea, and it's a real pleasure for me to be here. As a preventive cardiologist, education is one of my passions, so I hope that today I'll be able to teach someone something. I know you're a very informed audience, so I'll look forward to any questions at the end. But we're going to quickly just kind of go through a condensed review of lipid-altering therapies because there's a lot of possible therapies out there. It's just that we can't talk about all of them. I'm going to talk about the ones that are the most common and the ones that you're more likely to be familiar with. So let's see if I can advance my slides. Okay, great. So let's just start off with the title of this talk. This was a title that was given to me, so I want to make sure that we're all on the same page of what exactly lipid-altering medicines are. And basically, lipids is a biological term, if you will, that describes and includes within it your cholesterol as well as your triglyceride levels. So when we talk about lipid-altering medications, we're actually talking about medications that can affect your cholesterol levels, but they could also affect your triglyceride levels. And specific medications target one or both of these, but generally they're specifically targeting either your cholesterol or your triglyceride levels. But frequently they do have a little bit of effect on both of them. So that's what lipid-altering medications are. And then the most frequently asked question that I tend to get is whether or not someone needs to be on medications, because most people prefer to try alternative diet and lifestyle route before really having to commit to taking a medication. So we're going to dive into this in a little bit more detail, but the simple answer to this is people who are at a more than acceptable risk of having a future heart attack or stroke, these are the people who would need medications traditionally. So before we talk about the specific medications, I want to tell you about the strategy that most healthcare providers are thinking of when they see you in the office. They're actually trying to figure out what prevention strategy is best for you. And in order to do that, they actually have to put you into, oh, I'm having trouble with my slide here. For some reason, it's going forward. Hold on. There we go. They have to put you into a prevention category, if you will. And so let's just quickly talk about those categories. So the term primordial prevention is a term we use for preventing any risk factors from actually developing. So this is, for example, the Healthy School Lunch Program. In schools, your children don't actually have any heart disease or high cholesterol at that point, most children. And so using this kind of strategy hopefully is a form of primordial prevention, so preventing them from developing high cholesterol or obesity in the first place. And then we move on to primary prevention. Primary prevention is treating a risk factor, such as high cholesterol, before someone has any complications from that risk factor, such as a heart attack or a stroke. Then we have secondary prevention. Secondary prevention is treating the risk factors after someone has already had an event, such as a heart attack or stroke, with your goal being that you want to prevent this person from having a second or third or fourth event. And so as you can imagine, there's different goals for cholesterol management for different people who fall into these different prevention groups. And we'll kind of go into that in a little bit more detail. So as all of you know, the way your healthcare provider assesses whether or not you have high cholesterol or not is by a routine, what we call cholesterol panel or lipid panel. And that is some blood work that will give you your total cholesterol level, your LDL cholesterol, which we sometimes call the bad cholesterol, your HDL cholesterol, which we sometimes call your good cholesterol, and then your triglyceride levels. And in order to minimize risk, depending on what specific risk factors you have, but right now we're going to talk about cardiovascular risk. So in order to minimize your cardiovascular risk, we focus on the LDL cholesterol and the triglyceride levels. So what exactly is LDL cholesterol? This can be a very complicated slide, but I'm just going to distill down to you kind of the take-home points that I want you to take from it. So LDL stands for low density lipoprotein, which basically you can think of a lipoprotein as a taxi that carries around cholesterol and triglycerides inside of it. Those are the passengers. And so everything you see on this slide, the chylomicrons, VLDL, IDL, LDL, these are all forms of lipoproteins. The only thing that's different about them is the amount of triglycerides and cholesterol that they carry. And there's two ways to have increased LDL cholesterol in your body. One is depending on what you eat, which is kind of what this slide is showing. That's an apple, which has, pretty much zero cholesterol, but I didn't want to put a donut in there in case I was giving the wrong message. So basically, it's what we eat, and then also what the liver or what our body produces. So there is a cholesterol synthesis pathway that's happening, but there's also the external or extrinsic pathway, which is what we eat. So we're going to focus in now on the LDL cholesterol, which is the low density lipoprotein cholesterol, which means this area here, this yellow piece of this pie, is the cholesterol carried by the LDL particles in your bloodstream. And so before we zone in on the actual medications, there's just one prevention point that I will kind of want to bring up in the beginning now, and then I'll also talk about it a little bit later, is that whether or not your healthcare provider tells you to be on medications, everyone needs to participate in a healthy lifestyle. So that includes exercise, which is guidelines recommend 150 minutes per week of moderate physical activity. That means you should kind of break a light sweat, so it shouldn't just be a very leisurely kind of thing. And then in terms of diet, we have done some studies now looking at the benefits of a Mediterranean type of diet, and there seems to be a very good association with lowering your cardiovascular risk with a diet that's rich in olive oil, nuts, fruits and vegetables, and legumes. Now, the caveat to that in terms of diets is that, there's other diets out there that I'm sure you guys have heard of, specifically people who adopt a vegan lifestyle. They do tend to have incredibly low cholesterol levels. I'm not necessarily proposing that we all become vegans, but what I would like us to focus on is kind of going away from animal sources of food or intake in our diet is actually more healthy for us. So here we are all following an excellent diet, but even if we are doing everything we should, based on our blood work and our other medical conditions, we may come across a situation where we would need medications. So how does your healthcare provider figure that out? Especially for people who've never had any heart problems or stroke before. And the way that we tend to do that is very guideline driven. These are the 2018 HAACC cholesterol guidelines that tell us to calculate an ASCVD risk score, which is an abbreviation for atherosclerotic cardiovascular disease risk score. And they do that by plugging in various pieces of data from your medical history as well as your blood work. And if your 10-year risk is over or equal to 7.5% to have an event, at that point your provider may talk to you about starting medication. And remember that regardless of this, we are all going to recommend the diet and exercise lifestyle changes. So this is all in addition to the healthy diet and lifestyle. Now there's some special cases where your provider may tell you to start medication without you having to have gone through a ASCVD risk score calculation. And that's when your LDL cholesterol level is very high. And very high for the guidelines means greater than or equal to 190 milligrams per deciliter. And generally we start people on a drug from the family of statin drugs. Typically when levels are this high, it would be atorvastatin or rosuvastatin. If you've already had a heart attack or a stroke, you will also be given a statin, typically the atorvastatin or the rosuvastatin, because we know that the stronger, the more effective LDL lowering we have, the better the risk reduction is. And atorvastatin or rosuvastatins are our strongest drugs that we have for that. Now, if you're a diabetic between the ages of 40 to 75, the guidelines say that if your LDL is greater than or equal to 70 milligrams per deciliter, you may also be able to start a statin. It doesn't have to be the high intensity statin, but it kind of depends on your numbers beforehand, and you don't need to have a risk score calculation. If you're a diabetic with a lot of risk factors between the ages of 50 or 75, you may actually need a high intensity statin because we want to get your LDL lowered by 50% or more. Now let's say that you don't fall into this category of 7.5% or more. There are several other risk factors which the guidelines call risk enhancers. So if you have these, then that makes your risk for having a future event higher. And that means that maybe it would be better to be on medications even earlier. And we're not going to talk about all of these risk enhancers, but the three that have been kind of highlighted here are the HSCRP, which is the high sensitivity CRP assay. If that value is greater than or equal to 2, that is a sign that there's some inflammation in the body that is specific to cardiovascular events. If your triglyceride levels are high, which is greater than 175 milligrams per deciliter, again, that's a higher risk associated factor, so we might want to start medication sooner. And then if your lipoprotein A level, this is a lipoprotein that is not routinely checked with your traditional cholesterol panel. If your physician or healthcare provider gets that and that's greater than 50 milligrams per deciliter or 125 nanomoles per liter, depending on the kind of assay that they used, this is also a high risk feature. So these three are what we're going to focus on in the talk, but as you see in this slide, there are other things that would make someone be higher risk than their score calculation. So the main class of drugs that are very common and very widely used and quite well tolerated in general when we look at all of the people who are on them are the statin drugs. And I'm sure you're all familiar with statin drugs. They're a family of drugs that are basically small molecules that compete with the enzyme HMG-CoA reductase. HMG-CoA reductase is involved in cholesterol synthesis. So remember, we talked about earlier that one of the strategies to lower your LDL cholesterol is to stop cholesterol production. So this statins basically kind of block this enzyme from working well, and that results in a decrease in cholesterol production. What happens then is very, very interesting because the body, you know, it's in a balance. We're all in a balance. All our cells are in a balance or homeostasis. And body doesn't like it when things get too far off balance. So when there's decreased cholesterol production inside the cells, that triggers the cells to make more LDL receptor. So the LDL receptor, its job in life is to basically sit on the cell surface and pick up LDL that's flying by in the bloodstream. It picks it up and pulls it into the cell. So even though it's not a direct effect of statins, an indirect effect of statins is that you have decreased cholesterol production in the cell. The cell thinks that it needs more cholesterol, and so it basically sends more LDL receptors out to the surface, pulls in LDL from the bloodstream, and that results in lower LDL cholesterol levels in your bloodstream when you get your test. So statins are recommended by the guidelines as first-line pharmacological therapy to reduce LDL cholesterol levels and for the prevention of cardiovascular disease events. So the most commonly used statins, which are the high-intensity statins that reduce LDL cholesterol by 50% or more, are atorvastatin, which is otherwise known as Lipitor, and rosuvastatin, which is also known as Crestor. And these are very effective. As we mentioned, they can decrease your LDL cholesterol levels by 50% or more. The more moderate intensity statins are the simvastatin, which is Zocor, pravastatin, which is Pravapol, fluvastatin, which is not used that much anymore, and there's a couple more that are not used that frequently. Now, sometimes, even though you're on the maximum tolerated statin dose, if you're a very high-risk patient and we need to drive your LDL down below 70 milligrams per deciliter and you're not quite there yet, at that point, we suggest adding another agent, which is called ezetimibe. Ezetimibe is known as Zetia, is recommended to be used if someone's LDL cholesterol is not at goal and they need it to be less than 70 milligrams per deciliter. So what is Zetia? Zetia is a small molecule. It works by decreasing the absorption of cholesterol from your intestines. So it basically stops this receptor from absorbing cholesterol that's in your basically needs in your intestine, in your gut. And that also indirectly causes, again, an increase in this LDL receptor, which again will pull in LDL from the bloodstream. So you have a 2-for-1 effect with ezetimibe as well. If you give it as a single therapy, or even if you give it in combination with your statin drug, it will reduce LDL cholesterol by about 20 to 25% more. So if you're on a statin and you're at 50% reduction, this will add another 20 to 25% reduction. So that sounds great, but unfortunately, sometimes some people need more. And so if you're already on your max tolerated statin and you're on ezetimibe, but you still need to get your levels lower, the next agent that we use are PCSK9 inhibitors. Now, PCSK9 is a lovely abbreviation for a very long protein here. It's called proprotein convertase subtilissin kexin type 9. So none of us want to say that, so we always say PCSK9. And the job of your natural native PCSK9 in your body is to regulate the levels of these LDL receptors. So if you block PCSK9's activity, that actually increases the number of LDL receptors and again, decreases your LDL cholesterol in your bloodstream. Now there's two kinds of PCSK9 inhibitors. The most common that we have available here in the US that have been around for several years now are these monoclonal antibodies. They are targeted against PCSK9 and they prevent PCSK9 from binding to the LDL receptors. So they block it from doing its job. And this in turn, again, results in a higher level of LDL receptors available on the cell surface and causes us to have lower LDL cholesterol in our blood. They are incredibly effective. They reduce LDL cholesterol by 50 to 60%. So imagine if you're already on a statin and Zetia, and now you're having an additional 50 to 60% reduction. That's a lot of reduction of your LDL cholesterol. The two agents that we know of that we use here are evolocumab and alirocumab, are the most common. They're administered as injections and given every 2 weeks. Now, not available to us in the US is the second type of PCSK9 inhibitor, and that is inclisiran. This is a synthetic small interfering RNA, which basically prevents the PCSK9 protein from getting made. It's also given as an injection. You give it 2 starter shots relatively soon to each other, but then you only need 2 shots a year. So every 6 months, you get 2 injections. Now they've looked at this in studies, obviously, and they found that you can reduce LDL cholesterol level by 53% in people who have been given this. And that population that was studied, this was in addition to statin therapy. So it's very effective. It's safe, and in fact, when they looked at the time average reduction over 9 months, there was still more than 50% reduction in LDL cholesterol levels attributed to inclisiran. So again, very effective. But unfortunately, it's not yet approved in the US, but that might be happening, hopefully. It is currently being used in Europe. So I feel like I talked a lot about, and maybe a little bit fast, so I want to just summarize a little slowly the drugs that we talked about. And right now we're focusing in on LDL cholesterol lowering drugs. We talked about the statin family, and we've got the high intensity statins, which are the atorvastatin and rosuvastatin. They can cause a 50% reduction or more, so they're very effective. The pros of it are they come as a pill, just not hard to take, and they're relatively inexpensive because they're covered by insurance. The cons are there are some people who do get some side effects. It's a very small percent of people, but in those people, then we have to try some alternative strategies. Ezetimibe, which we also talked about as an adjunct to statin use or as monotherapy, it has moderate effectiveness in that it can reduce your LDL cholesterol by 20 to 25%. The good news is it's a pill, so it's easy to take, it's covered by most insurance, and it's actually very well tolerated with less side effects than statins. The cost, if it's not covered by insurance, is pretty expensive, but I think for the most part, insurance seems to cover it quite well, so we're okay in that regard. Then PCSK9 inhibitors, we talked about the antibodies against PCSK9. They're strong in terms of their effectiveness. They'll lower LDL levels by 50% or more. You only need to take them once every 2 weeks, and there are very few side effects, but they are an injection, so some people don't like to use them. And then they are very expensive if they're not covered by insurance, and getting them covered by insurance sometimes is a bit of a hassle. So that's one of the downsides, but they are an excellent drug. And then PCSK9 inhibitors, the small interfering RNA that we talked about, it's also very effective. It's even, you need to use it even less than the antibodies, just twice a year injections. But so far we don't have it, and we don't know how expensive it's going to be. Okay, so there are other drugs that we use to lower LDL cholesterol. They're not used as commonly, so some of you may not be familiar with them, but I just want to touch on them briefly because they may be becoming more commonly used. So the first one is bempedoic acid. This is an oral prodrug, which means it's not active when you eat it. It becomes activated in the liver as it passes through there. It blocks an enzyme called ATP citrate lysase, which results in decreased cholesterol production because ATP citrate lysase, or ACL, is in the same pathway as HMG co-reductase. It's just a little bit further up from it. So the overall effect is to decrease cholesterol production. Remember that this again makes the cell think that it needs more cholesterol, so LDL receptors get upregulated and LDL gets pulled out of the bloodstream into the cell. So it increases your LDL clearance. It's an oral medication, which is great. So it only needs to be taken by mouth and once a day. So there have been several trials looking at bempedoic acid. They all seem to have a kind of a psychological name to them. They're called Clear Wisdom, Harmony, Tranquility, and Serenity. I don't know why they chose those names, but they sound good. Unfortunately, the LDL-C reduction, it's not as effective as the high-intensity statins or the PCSK9 inhibitors. There's a moderate 15 to 20% reduction of your LDL cholesterol. We don't currently have any data with respect to outcomes, so we don't know if adding this agent improves cardiovascular event rates. We do know that it has a low price and it's an oral drug, so that's all good news. It also was designed specifically to avoid myalgias, which is one of the top complaints people have, those people who are having some side effects complain of myalgias. So that side effect is much less. It does work in the same pathway as we mentioned as the statins, but it's not present in your skeletal muscles. So again, less myalgia side effects. The cons, though, are that, as we talked about, it's not quite as effective as patients who are on maximum intensity statin. And it's also not as effective in patients who are already on high intensity statins based on these trials that were done. Now I'm going to talk about the two other drugs, and those are ones that are currently only approved for people with homozygous familial hypercholesterolemia or homozygous FH. Lomitapide is the first one, and that is one that inhibits very low density lipoprotein, which is VLDL lipoprotein, or sorry, VLDL production. And that is, if you remember the slide I showed you before, that's a little bit upstream of LDL. And it therefore causes a decrease in LDL production and a decrease in LDL's cholesterol. It can be used with other therapies, but right now, again, it's only for homozygous FH patients. It is only a once-a-day pill, which is very good. The main side effect to watch out for, however, is liver toxicity. So there does need to be some monitoring for that. But in patients who can take it, it causes a 40% reduction in LDL cholesterol. And that was in patients who are already on statins, so it's quite effective. The second drug now we're talking about is evinacumab. This is a recently approved, just in February, approved drug for, again, homozygous FH. It is a monoclonal antibody against ANGPLT3. and it blocks its action. So ANGPLT3 is itself an inhibitor. It stops the breakdown of triglycerides and other lipoproteins that we showed in the slide. So if you block the inhibitor, you actually improve reduction of LDL cholesterol. The downside is it is given as an infusion, so every month people have to go in and receive this infusion. But it has a very good efficacy profile, about 47% reduction in LDL cholesterol at 6 months in these patients who received it. So to summarize quickly then, we just talked about medications that lower your LDL cholesterol. We talked about statins, ezetimibe, PCSK9 inhibitors, and bempedoic acid. And then for patients with homozygous FH, LOMITAPIDE and EZETIMIBE are relatively newer drugs that also are very effective. Now let's talk about residual risk. Residual risk is risk attributed to other factors when your LDL cholesterol is at an excellent level, but people are still at higher risk. That's when we try to look at other factors that need to be fine-tuned to improve people's risk. So let's talk about triglycerides now, and triglyceride-rich lipoproteins. That's a term that you may hear. So we're going back to this original slide. We had originally focused on the LDL part of the pathway, but now we're going to talk about the triglyceride-rich lipoproteins, which are all of these lipoproteins. You don't traditionally get these checked when you do a routine cholesterol check, but the triglyceride content of the lipoproteins is checked. So we have that information. And there's been a lot of focusing in on triglycerides relatively recently, actually. It was important previously, then we kind of got focused in on LDL cholesterol. And then now that we've done a lot of studies on LDL cholesterol, we're coming back to the triglyceride part of this story. And so what we know now is that when you check your triglyceride levels, fasting and non-fasting, they are both associated, independent of your LDL cholesterol, with increased cardiovascular risk. So they are a separate risk factor that needs to be taken care of, basically. So even if your LDL cholesterol levels are low, if your triglycerides are high, you're still at increased risk to have a cardiovascular event. The ideal fasting triglyceride level should be less than 150. It should be, you know, the lower the better, but less than 150 is the cut point that we currently use. And then the ideal non-fasting triglyceride levels should be less than 175. Now, there's a lot of drugs that have been used in the past. Fibrates family of drugs are very common, so I'm going to talk about those. And those act on this peroxisome proliferator activated receptor alpha, or PPAR alpha, which are transcription factors that affect the gene expression and lipid metabolism that we kind of looked at in the previous slide. They're going to affect lipid metabolism. They've been used for 50 or more years, so they're well known in the community. They lower the concentration of triglycerides. They also have this effect of lowering LDL cholesterol and C-reactive protein, as well as increasing HDL cholesterol. But the main reason to use them is triglyceride lowering. The most common fibrate that most people have heard of is gemfibrozil. It does have some side effects, including liver toxicity and some GI side effects. And unfortunately, side effects are a bit more common in people who are already on statins, so they're not an ideal drug. Now, pemafibrate is a selective PPAR alpha modulator, meaning that it hopefully has less side effects than the traditional fibrates. And there's been a lot of interest in this drug. It's been found to decrease triglyceride levels more than 30%, and it's pretty well tolerated. It is being studied right now in a very large clinical outcomes trial called Prominent, and that trial has recruited patients with high triglyceride levels as well as low HDL cholesterol levels. So when the results of that come out, we'll have information about whether pemafibrate pemafibrate-related lowering of triglycerides is associated with improved cardiovascular outcomes. Now, much more commonly used and actually used even without a prescription are omega-3 fatty acids. I'm sure everyone has heard of them. they have a very favorable effect, a lot of biological effects, including anti-inflammatory effects, antioxidation effects, antithrombotic effects, and they are also, all of these effects seem to be tied in with CBD, so they taking them should be beneficial. Now, we have marine-based and plant-based omega-3 fatty acids, as we know, but recently studies have really been looking at the marine-based omega-3 fatty acids. And remember that all omega-3 fatty acids are not created equal, and it turns out that maybe what's in your that fish oil pill is actually quite important. So is it mostly eicosapentaenoic acid or EPA? Is it a combination of eicosapentaenoic acid and docosahexaenoic acid or DHA? That seems to be important. And we know this because of the recent REDUCE-IT trial, which used a pure EPA formulation of eicosapentaethyl. And that was given in a much higher dose than we typically take, 4 grams per day dose, and seemed to be associated with decreased mortality in the patients who took it. There was a side effect of an increased risk of atrial fibrillation, however, so if you're getting this drug, that's something that you can talk about with your healthcare provider. Now, just even more recently than REDUCE-IT, just a few months ago, the STRENGTH trial looked at tried to answer the same question as REDUCE-IT, and they looked at a formulation that had both EPA and DHA, and they actually found no significant outcomes benefit. So there's more to be talked about in terms of the results of both these trials, and that work is going to be ongoing, I'm sure, but stay tuned for that. Now, what about increasing HDL? We talked a lot about lowering, but as you know, HDL, we've been terming that as the good cholesterol. So HDL cholesterol, how about increasing that? So we looked at this in several trials, and unfortunately, there seems to be no benefit from any of the drugs that we use to raise HDL cholesterol. Now, that doesn't mean that your HDL cholesterol doesn't get raised when you use some of these drugs, and notably niacin, which was used a lot in the past, which is kind of less used now, and the fish oils also will increase your HDL cholesterol. But we still don't know if that raising of it has a direct benefit in terms of outcomes. But typically what we tell people who have lower than ideal HDL cholesterol is to really drive down other risk factors. So having a good diet and exercise strategy, a smoking cessation, and also good control of your other risk factors such as diabetes, that is what we recommend. And interestingly now, we've also had a thought concept in the field, basically, that women after menopause, they tend to have high HDL levels, but unfortunately some of them seem to have increased cardiovascular risk. So we're thinking that maybe it's not the absolute number of your HDL cholesterol that's important, but maybe the HDL function that's more important. And so there's a lot more coming through the pipeline with respect to looking at this as well in the future. So let's just briefly talk about inflammation. We mentioned that hsCRP is a marker for increased cardiovascular risk and is a marker of a low-grade inflammation. So how do we decrease that? And kind of fortuitously, statins actually decrease your hsCRP levels, and fibrates, which not many people are on, but if one was on a fibrate, those also have been found to decrease hsCRP levels. And of course, diet and exercise and good blood sugar control, these all also decrease hsCRP. So we continue to advocate for the diet and exercise piece of this. Now, finally, I want to move on to lipoprotein(a). Lipoprotein(a), again, it's not traditionally screened for. If you have an early family history of premature heart disease, sometimes your healthcare provider might do this. Sometimes you may ask for it and they would do it. But basically, lipoprotein(a) is an LDL particle, which has this additional ApoA attached to the ApoB part of LDL. And so we think that it's a difference in the size of, we shouldn't have done that. A difference in the size of the ApoA is related to a difference in the level of the LPA in the blood. It's an independent risk factor for coronary vascular events, despite being having LDL, that's that goal. If you have high LPA levels, that's increased risk for you. Now, we can't change that LPA levels by diet and exercise as they're genetically determined. You can get some modest decrease with PCSK9 inhibitors, and you can get a little bit of increase with statins and ezetimibe, so that is there. Now, we do have a solution for high LPA levels. We've got an antisense RNA, we've got more than one actually, in the works, which blocks ApoA production, which in turn blocks LPA production. And so we do see that there's excellent knocking down of LPA levels in the bloodstream, but these drugs are still not available. They're still being studied. So more to look forward to in that regard. So to summarize, we did a very quick overview of ways to reduce one's risk, as well as the lipid-altering medications. Remember that regardless of being on medications or not, diet and exercise are always needed. And if we don't do that part, if we rely just on the medications, that's kind of like swimming into a current. So you're actually decreasing the efficacy of your medications and maybe even having to take higher doses of them if the diet and exercise piece is missing. We talked about LDL cholesterol reduction, which is one of the mainstays of lipid-lowering therapy. And there's a lot of drugs out there that we talked about that can get pretty effective LDL cholesterol reduction. We talked about triglyceride and triglyceride-rich lipoprotein reduction, and there's more in the works with the prominent trial coming, so let's stay tuned for that. Inflammation reduction is a happy side effect of statin and fibrate use, so that is a wonderful thing, as well as, again, diet and exercise will reduce our overall inflammation. And LPA reduction, again, that's in the works, but hopefully that reduction will also be correlated to improved cardiovascular outcomes. Because there's a lot of people who we think have elevated LPA levels who don't know that they have it yet. So that, again, it's coming. And with that, that's my last slide. So I'd like to thank everyone for staying tuned, hopefully, and look forward to your questions.
Thank you so much. That was great. Lots of really good information about all of the different medications that can be prescribed. I would like to go ahead and launch the poll, and then I can't wait. I'm going to introduce Rob Ray, who is going to give us his perspective from a patient's standpoint on all of the different medications. But first, we want to test our theory on what you've learned during the webinar. So please answer your question. The question again. How do the medications lower LDL cholesterol in the bloodstream? Everybody is answering and filling them in. Great. I'm just going to give everybody about 5 more seconds. And Dr. Faruqi, you'll have to let us know how we did. All right, I'm going to go ahead and end the poll. Here are the results. How did we do?
You did great. I'm really happy. The correct answer is increasing the number of LDL receptors on the cell surface.
Great, great. Hey, Rob, are you here with us still?
Yeah, I'm here.
Great. You can choose to share your screen if you'd like, or if you would just like to talk. We'd love to hear a little bit about your journey and anything you have to ask questions, any questions you have, we'd love for you to ask them now.
Yep. Okay, there we go. I had to close the shade. The sun was blinding me. But anyhow, thank you everyone for attending this afternoon. Thank you, Dr. Faruqi, for your great presentation. In 2009, I wound up having a heart attack and was in my 40s, active, played ice hockey, skied, softball, ate a Mediterranean diet, wound up having quintuple bypass surgery. And in my quest to find out how this happened to me, it actually took going through a few cardiologists and finding someone that would look at my case and try and determine what caused this. So I'm going to share my screen here a second. So this is my blood test, and move this out of the way. Can everyone see this? So,
Yes.
and Dr. Faruqi can comment, but this number here in red, 298, that is my Lp(a) score. And as you can see, it's in red for a reason. It's well above where it should have been. And my particle sizes were very small as well. So this is what caused it. And, you know, when the doctor found out these results, it was easy for him to predict what caused my heart attack. So you can see, though, here's this is from 2019. Even though my cholesterol is, you know, pretty low and triglycerides and everything is in good shape, you know, I'm still dealing with this genetic issue of lipoprotein A. So, you know, I'm going to stop sharing. I've had to do everything I can, as my doctor describes it. I have to balance the scales in my favor, and that means eating the right food. So I've read a lot on nutrition and tried to eliminate any foods that cause my body inflammation. I exercise regularly to keep my cardiovascular system as optimal as possible. I can say, fortunately, I went back to playing ice hockey a year after my quintuple bypass surgery. I'm still very active, and you know, I'm hoping that I'm going to live a long and fruitful life. I do have to thank Mended Hearts for coming into my life. When I was in the hospital recovering from surgery, two gentlemen from Mended Hearts came into my room, and one of them was a surfer and the other was a speed skater. So they gave me a lot of help, hope, and motivation that you can have life after a hard event. It may take some changes to your lifestyle, but changes that you can control yourself. And but you know, I really am fortunate to have found Mended Hearts. Again, my genetics are my genetics. I can't change them, unfortunately. But you know, educating myself, having a support group like Mended Hearts certainly helps me continue to live a fruitful life. So, you know, I do, while I have the podium here, I have a question for Dr. Faruqi. You know, lipoprotein A hasn't really been on a lot of people's radar. I understand approximately 1 in 5 people may have this condition. And I know, I think in 2018, it was the first time there was an ICD-10 code for it established. So why aren't cardiologists testing more for lipoprotein A?
That's a great question, and one that people like the National Lipid Association are really focusing in on, because part of it, I believe, is awareness. You know, we need to be a bit more good as a medical community of educating other physicians as well, that this is an important risk factor to look for. If you don't look for it, you don't know about it. Another part of this is the fact that if you have it, we still don't know exactly what to do with it. At least that's what a lot of physicians have told me. So apart from really driving down the LDL cholesterol levels, there's not much more that we offer people. Some people, there's apheresis, but that's it's limited to very, very high risk people with multiple events that can't be controlled. So, and it's not ideal for, as you mentioned, 20% of the world's population who may have elevated levels. We also don't know like how different ethnicities associate with different LPA levels. For example, African Americans in general have higher LPA levels, but does a value of, let's say, 100 in someone who's African American mean more or less risk, compared to someone who's not? So there's a lot of unknown out there, but I think the number one reason is physician awareness of actually getting the tests. And the National Lipid Association put out a very nice kind of statement about LPA and what to do with it. And there's actually a global think tank also kind of going through how to best increase awareness and what to do with values once you get them, and standardize. Another problem has been standardizing the way that you measure lipoprotein(a), and so we just recently decided that using the nanomolar approach was better than using a mass-based approach. So there's a lot of unknown out there, but definitely more awareness is needed. And I'm pretty sure that if people asked to be tested for it, they would not meet resistance. It's just that, it's not something that you would think to ask if you're not aware.
Right. Are there any clinical trials going on in the US on drugs to combat Lp(a)?
There's a couple of trials. They're using these small interfering RNA that I talked about, and then also like antibodies. So I believe we're in phase 3 now. There's actually excellent reduction of LPA levels, but we don't know, we've got to wait for the trials to be finished. And then also we don't know how that would correlate with outcomes. But we're hopeful. I mean, if all of the other data that we have would suggest that lowering the levels hopefully will not cause any other unknown, kind of pathways getting activated that would be worse off for patients.
Right. Well, that's great news. Thank you so much for informing us of that.
Of course.
Yeah, great. Thank you so much. And Rob, thank you for sharing your blood panel with us. It was really great to be able to see a real panel from a patient and kind of understand that. So thank you very much. We are going to do one final poll while we are doing a last call for questions. If anyone has any questions that they would like to have answered, we do have a few minutes, but we'd really love to get your opinion on the webinar and how we did, and if you all think that you learned anything, and if we could do anything better, that would be great. Mandy is going to ask the questions. They are in the Q&A section. So if anybody has questions they want answered, go ahead and put them in now. And Mandy, I'm going to turn it over to you to moderate the questions out.
Thanks, Andrea. So, Doctor, we've got quite a few questions that revolve around this topic in general. What percentage does genetics versus diet and lifestyle determine a person's cholesterol levels?
Yeah, that's kind of very patient specific, because obviously if you've got homozygous FH, there's only so much you're going to be able to do with diet and exercise. So there's definitely people who are heterozygous FH who can have a good effect from diet and exercise, but who will still need medications. And then the rest of people who don't have a genetic a predisposition, I have seen quite dramatic reductions with good diet and exercise. So I would say that we shouldn't just assume that it's all going to be genetic. There really is a role for diet and exercise. In fact, you can get a reduction of 50% or more with excellent diet and exercise, but it is very patient specific. So I don't think I'd be able to, say that for everyone.
Thank you.
I hope that answered the question.
Yeah, I know it's a tough one to answer. That was a nice general statement, though. Thank you.
Okay.
I don't know if I'm understanding this question exactly, but it says of patients on statins, the coronary calcification score is 0. Can you comment on that? Does that make sense to you?
Right. So it does. I think I know what the questioner is asking. So sometimes what we do is we use a coronary calcium score to help us decide whether someone should be on a statin or not. So this is typically someone who doesn't meet the criteria yet for high risk, and so they're on the fence about maybe starting a statin or not. If you have a CAC score, a coronary artery calcium score greater than 0, that's a sign that some of this plaque deposition has already started. And so that tends to tip us in favor of using a statin in those patients. Now, of course, it depends on other things like other risk factors, age, etc. But generally, a score of 0 is a great thing. It means your 10-year risk of having a cardiovascular event is like very, very minimal. But if you're 20 years old and you've got a CAC score, that's less helpful because things change over time. In fact, age is the biggest risk factor that we don't have a cure for. So if you are on a statin and your CAC score is 0, that means that somebody decided to put you on a statin before you got the CAC score. So there must be other risk factors there, I'm assuming. But the good news is your CAC score is 0. So all of the things you're doing to control things are working. Without knowing more of the history of I'm assuming this is how things went about.
Thank you. The next question Charlotte asks, is 80 milligrams of atorvastatin more likely to cause side effects than 40 milligrams?
Well, it's, generally, like a rough rule of thumb is higher doses are increased likelihood. But unfortunately, sometimes we need higher doses, especially, if you are someone who's already had an event or very high risk, and you don't get as much benefit from the 40. Remember, atorvastatin 80 is the max dose, which should give more than 50% reduction in your LDL levels, but it's very variable. Everyone, there's some people who are very good statin responders and then other people who are not. Now, sometimes when you're on this very high dose and you're still not responding, that's another trigger that maybe you should get your Lp(a) checked, because remember, Lp(a) has that LDL attached to it, so it kind of goes in with the traditional LDL cholesterol measurement might still be high because of high Lp(a), which is not affected by statin use. But I would not stop taking atorvastatin 80 because people have been on that drug for years and have no side effects. And so a word about the statin side effects is that, true statin side effects are incredibly rare. Unfortunately, there's been a lot of maybe misinformation in the media as well about statins. So sometimes any little ache or pain is attributed to the statin, but it's not necessarily actually giving you rhabdomyolysis or liver toxicity. So that's a discussion you really need to have with your healthcare provider before saying that it's your statin that's causing any side effect.
Okay, thank you.
Mm-hmm.
What's the effect of pregnancy on your lipid and triglyceride levels?
So pregnancy, of course, it's not a normal state for ladies to be in all the time. It will increase your total cholesterol and your triglyceride levels. Now, there are some, you typically because there's some side effects to fetuses with medications such as statins. It's not you wouldn't necessarily start treatment with them during the pregnancy, but there's special, cardiologists who kind of focus in on pregnancy-related dyslipidemias and other outcomes. So that they would be someone to see if the levels were really quite high.
All right, and we've got time for one more question. I know that this has come up a lot in the news over the last few years about why the PCSK9 inhibitors are not offered by, your cardiologist. They don't prescribe them. So Cherie is asking about that. Basically, she says the costs, especially for insured patients, are right in line with other branded drugs. A friend of mine pays $3 a month for Repatha. My dad had a heart attack a few months ago and his cardiologist didn't prescribe the PCSK9 inhibitor. So I've been doing research on the best available products and noticed that the inhibitors have the best reduction on top of a statin. So can you just comment on that and the issues surrounding it?
That's that might be a question beyond the scope of my knowledge base, in the sense that I don't know why. I know that even though it is covered by insurance, it's still sometimes quite hard to get it covered by insurance. So you really have to prove that someone is at increased risk or had a recurrent event, or you know, it's not as easy as maybe it sounds that it is. As far as I know, it tends to be insurance driven because unlike Lp(a), PCSK9 inhibitors are, you know, everyone's aware of them and everyone knows how effective they are. So what I know of, it tends to be insurance driven. Now, there may be some other, you know, maybe if you're already at goal and you don't need it, that's something else. But the first line is always a statin drug. And then as you saw with the guidelines, PCSK9s are actually not even second, it's their third line, which I believe is related to insurance, but you may have to ask someone in administration or pharmacy for that.
Great, thank you so much. Mandy, thank you for moderating those questions. If your question was not answered, we can work to get you the answers to your questions. If you have any other questions, you can reach out to me. My email is on the screen. Just to wrap this up, I just want to make sure everybody knows that next Tuesday, April 20th, we will be right back here at 3 o'clock Eastern in our next session of the series, and this one will be focused on sex-specific risk factors for heart attack and stroke, and that will be with Dr. Bond and our patient Lee Parker. So thank you both for being here so much with us. Rob, we appreciate you, and Dr. Faruqi, thank you so much for spending your hour, and everyone have a great day.
Thank you very much. Thank you for inviting me.
Bye-bye.
Thank you. Bye.